Well, good afternoon and welcome to our first grand rounds of 2026. We appreciate you adjusting to our new lunchtime schedule and offer a welcome to everyone joining us from Midtown via live stream. In addition to all of these changes today, it is also Winship's very first Scarborough Grand Rounds lecture. This accolade is given to one speaker each month for Grand Rounds and honors Elliot Scarborough, the first director of the Winship Clinic founded in 1937. Dr. Scarborough was a visionary leader, and he was instrumental in shaping cancer care in its earliest days, educating the public, advancing treatment, and expanding the clinic to serve thousands of patients in Georgia. His legacy of leadership and commitment to patient care continues to inspire the work of Winship today. With that in mind, I'm pleased to introduce Dr. Holliday, Associate Professor in the Department of GI Radiation Oncology at MD Anderson, a team known for its deep expertise in treating the full range of GI cancers with advanced radiotherapy technologies, including IMRT, SBRT, and proton therapy. Dr. Holliday treats all GI cancers, but is widely recognized for her work in anal and rectal cancers. She is passionate about late toxicities and functional outcomes that impact our patients as they navigate life after cancer. She is also active in medical education and has authored more than 140 research articles and several textbook chapters. Please join me in welcoming Dr. Holliday.
Thank you so much for the kind introduction. I'm so thrilled to be with you guys today. I've enjoyed my time with the residents this morning and meeting several faculty, and I'm thrilled to get to talk about a topic near and dear to my heart, if I can figure out how to work your stuff. Next. You would think I used advanced technology for a living or something, right? Okay. All right. So, my hope is to spend some time with y'all today talking about late toxicity and functional outcomes after pelvic radiation, specifically for patients with anal and rectal cancers. But I think some of the principles that I'll touch on in the next 45 minutes or so are definitely applicable as our patients navigate life after cancer for many types of malignancies. I want to start my time together with you guys with a little story. The year is 2020. I was 3 or 4 years out of residency, kind of beginning my career as an academic radiation oncologist. And as sometimes is the case, your senior colleagues will call you and say, I've got the speaking engagement I was asked to do. I can't do it. Could you please step in? So the thing I was asked to do was to speak at a anal cancer survivor patient seminar. And the ask of me was really simple. I was asked to give like a 10 or 15 minute overview of radiation for anal cancer. And I thought, I can do that. And so I prepared this talk. I went to the seminar. I gave my little spiel. And what I wasn't expecting was how transformative the Q&A session after my little talk would be for the rest of my academic career. Because what I wasn't prepared for was the things that patients wanted to share and the things that they wanted to ask. I thought people were going to ask me, what is a gray? Should we give 50 gray or 50.4 gray for T2 anal cancer? Nobody wanted to talk about that. What they wanted to talk about was how they were feeling in survivorship and how they felt their teams could have better supported them as they navigated some of these issues. This quote has stuck with me for many years, and it served as the jumping off point to several lines of inquiry that I'll share with you guys through the rest of these slides. And I'll read it to you. She said, while I'm grateful to have my life, I feel blindsided by the toll cancer treatment has had on my body. Now I spend all day managing my bowels. I can't have sex with my husband. My bones hurt, and I'm tired. I shouldn't feel this way at 45. I wish someone would have told me that this could happen. And when she said this, I could feel my heart drop to my feet. I felt this sense of sorrow and regret and almost shame. I didn't treat this patient. I was meeting her for the first time, but I couldn't help but wonder how many of my own patients might be having these same thoughts in the privacy of their own homes that I didn't even know about. And it really was a formative moment for me, uncovered how much we still have to learn about the toll our treatments have on our patients. So I started to wonder, is it just this patient who I met at the seminar? Is it just me? Is it just my patients? How common is this that patients are unprepared for the late effects of our treatment? I'm a radiation oncologist, so I'll be focusing mostly on the side effects of pelvic radiation, but I think this is a concept that can translate. I think patients are unprepared for the late effects of our treatment, first and foremost because we as physicians, as providers, probably don't spend enough time talking about it. And it's fair. We have a lot to cover in a consult visit. We have to talk about their cancer. We have to talk about staging. We have to talk about what their treatment is. Sometimes there's multiple treatment options we have to discuss. In the time limitations of our clinic visits, sometimes we don't make it to late toxicities and what life after cancer looks like. And there are some studies that have looked at this. There are some studies that have done audio recordings of consult visits and shown that maybe up to almost 50% of discussions about pelvic radiation don't even touch on important and potentially life-changing late and permanent side effects such as sexual toxicity. We also know, and there's data to support this, that even when we do our job, even when we do a good job discussing potential late side effects of treatment, patients can't be expected to retain and memorize and keep with them every little thing that we say. We meet patients at some of the most vulnerable times in their lives. They're wondering if they're going to even make it through treatment and to the other side of cancer. Maybe what could or could not happen to them 5 years down the road may not be top of mind. And there's some data to suggest even when physicians do mention some of these potential late toxicities, when asked to report what they spoke about with their physician, about 50% of patients can remember every topic that was discussed. So it points to a principle that we can't let patient education stop at the consent form, right? We can't let it stop at the consult visit. Patient education and shared decision-making and discussion about these issues has to be a longitudinal conversation rooted in a real relationship. And then finally, as physicians who treat patients with cancer, we are a data-driven bunch. We like to have numbers and statistics to back up the advice and recommendations we give our patients. By and large, data on late outcomes, late toxicities are relatively lacking in our published literature. And those of you guys who have run trials or participated in trials know how hard it is to keep good follow-up patients that are treated and keep collecting these toxicity outcomes over months or years. And so, it's easy to collect and report local recurrence. It's easy to collect and report, maybe 6-week or on-treatment toxicity, but we don't have as much information to counsel our patients about late effects. Luckily, this is changing, and I do think we're getting better in this regard. So, as an example, I pulled RTOG 0529, which was a phase 2 study looking at IMRT for treating anal cancer. And we do have, in the 2022 publication, some data on late toxicity. But these are physician-graded toxicity scales. We've got some numbers we can look at here, and we can quote to patients on their likelihood of having late grade 3 or greater GI toxicity after treatment is done. But what does that mean? Grade 3 toxicity in the CTCAE is defined as a severe or medically significant, but not immediately life-threatening hospitalization or prolongation of hospitalization. So, what does this mean for the patient living their life after cancer? Does that really tell the full story and encompass every potential outcome or toxicity of treatment that could impact how they live their life? We know that how physicians see and grade and report toxicity is not at all how patients will see it or describe it themselves sometimes. We know that these physician-graded toxicity scales where we circle grade 1, 2, 3, 4, hopefully not 5, are very cut and dry. How many bowel movements are you having per day? Are you having bleeding that requires hospitalization or an endoscopic procedure? These are things that you would think would be easy for physicians to get right, but the data show us that these physician-graded toxicity scales are ripe with interpretation bias. The residents in the group know this. How many times have you gone in to see a patient and they tell you something about how they're feeling or how they're going. Your attending goes in and sees that same patient. How often will they maybe see or hear a different story? So interpretation bias is a problem. Observation bias is also a problem. And I think the biggest problem with these physician-graded toxicity scales is they significantly underreport low-grade but longitudinal symptoms. So if I have a patient, maybe they never had a bleed that was significant enough to need argon plasma coagulation, but they're pooping their pants 1 or 2 times a week for life. That's not a grade 3 toxicity, but I would argue that has, a bigger impact on how they live their life and survivorship than maybe a one-time rectal bleed that bought them a 2-day trip to the hospital. So if, physician assessed toxicity doesn't really tell us the full patient experience after treatment, we can't trust doctors to be accurate reporters of this, who should we ask? I think the answer is easy. We should turn to the patients themselves. And so there is this movement, this growing emphasis on the collection and study and reporting of patient-reported outcomes. And these are defined simply as healthcare information, health-related information obtained from the patient without or with minimal interpretation from the healthcare provider. And they have lots of benefits in addition to kind of cutting the middleman and minimizing those sources of bias that we talked about. They can also get at different dimensions of the patient experience. So not just how many times a day do you poop, but what effect does that have on your life? Do you schedule pick up and drop off of your kids differently because you're not sure when you're going to finish having bowel movements or when the next one might happen? So they have a lot of benefits and tell us a lot about the long-term impacts that our treatments have on our patients. So after kind of doing this little foray and trying to educate myself on how our patients are doing after the treatments that we give them, it prompted this little project that I did with several residents at MD Anderson at the time. In 2021, we set about with the very simple goal of asking our patients how they're doing. We compiled and sent out surveys to all the patients we had treated over the last several years for both rectal cancer and anal cancer. We targeted folks who were at least 2 years from completion of their treatment without evidence of disease. So they were into survivorship without any active cancer. We surveyed a little over 200 patients treated for rectal cancer and got 123 patient surveys back. And the next couple slides will focus on what we learned from the patients who were kind enough to share how they were doing. When we compiled this instrument, this is a kind of a broader problem in the study of PROs. If you throw a rock, you'll hit about 25 different patient-reported outcome measures. How do you know which ones are meaningful? How do you know which ones are worth the time that our patients will spend filling them out? I didn't really know in 2021, but I read what a lot of the ongoing cooperative group trials were using, what had been published on at the time, and this is what we landed on. We used the FACT G7 to get some general information about quality of life. We used LARS. Our colorectal surgery colleagues use this quite often for patients treated with surgery for rectal cancer. It tells about anorectal function. And then a nice complementary instrument called the FIQOL, which talked about not only fecal incontinence, do you have it, but what impact does that have on what you do in your life? We used the ICIQ for urinary function, and then we used FSFI and the IIEF5 for sexual function for women and men, respectively. So looking at bowel functional outcomes, what we found as we looked at this cohort of folks treated for pelvic radiation for rectal cancer is a fair number of them met major LARS criteria, meaning they were having issues in these domains of variable, unpredictable bowel function, maybe altered stool consistency with more diarrhea, urgency, and then, obviously incontinence, which can be the most distressing part of the symptom complex for our patients. Looking at the FIQOL results, the numeric score maybe doesn't mean a whole lot, 16.7, but what that translates to is that most of our patients are, at least in some way, having to modify their daily activities based on the unpredictability or the changes that they've had in their bowel function. And this is 2 years out from cancer treatment without any active cancer at the time. Michael Rooney, who's now treating GU actually at MD Anderson, he was a resident at the time. He set about doing what residents are really good at, kind of looking and performing analyses to see if there were any predictors we could find of folks that have better or worse patient-reported bowel function after treatment. What he found was, maybe unsurprisingly, folks that were able to get to non-operative management and didn't require surgery for their rectal cancer tended to have better bowel function, both in terms of LAR score and the FIQ-OL. Since we did this little kind of retrospective peek back, there have been more published data in the realm of patient-reported bowel functional outcomes for patients treated for rectal cancer. For a while, the short course versus long course debate was a hot one. In addition to the discussions on maybe relative merits for efficacy, there were also discussions on how short course versus long course might impact these long-term functional outcomes. Rapido data showed that there weren't any differences between major LARs when patients got short course or long course. We saw this also in our small survey cohort. And then there have been additional published studies looking at the non-operative management setting, and I think there's a growing body of data that do support if optimizing bowel function is the goal, then avoiding surgery when it's safe to do so is probably the way to go. So what about sexual function? We saw a couple years ago the publication of the prospect data, which really showed, we talked about how we can maybe optimize function when we're able to omit surgery, but what toxicity does radiation bring to the party? The prospect data showed us the additive toxicities when we add pelvic radiation to neoadjuvant, compared to neoadjuvant chemo, when everybody gets the same surgical treatment for patients with rectal cancer. And the big benefit, at least in the prospect data, for being able to omit pelvic radiation is in terms of long-term sexual function for both women and men. Interestingly, although there was kind of an early separation of the bowel function scores, instead of LARS, they used the MSK-BFI here, the long-term outcomes, 12 months and 24 months after surgery, didn't seem to be significantly worse when we used radiation or when we didn't. So I think there is a lot of opportunity in the space of rectal cancer treatment to utilize and incorporate patient-reported outcomes into shared decision-making with our patients. I know a lot of you guys treat patients with rectal cancer, as I do. You know our consult visits are getting longer. They're getting more complicated. Patients have more options. We might see a patient who might fit the criteria for prospect, but they also might require a low anastomosis for their LAR, and they might be expected to have some bowel dysfunction, even if they can have sphincter preservation, and they might be a candidate for non-operative management. And so I think we have some data to help inform these conversations now, but more prospectively collected data are going to be really helpful to partner with our patients in shared decision-making and help them kind of identify their own quality of life and functional priorities in survivorship as we navigate choosing between multiple potential treatment options in the multidisciplinary space. Okay, pivoting a little bit to our anal cancer cohort of our little survey study. I worked with Brian Day and Kelsey Corrigan, residents at the time, on this project. We surveyed a little under 250 patients definitively treated for anal squamous cell carcinoma who, again, were alive without evidence of disease 2 years post-treatment. We used the same survey that we did in Michael Rooney's study, but Kelsey had a fabulous idea. All the good ideas in any of my projects have come from residents. This is no exception. Kelsey had the idea, in addition to the PRO survey, she had some unstructured questions at the end that basically said, what do you think we should know about your life after cancer? What do you wish you had known when you were at the onset of this that we can use to help future patients? And I'll tell you, I'll report some of the numeric answers and the median scores and all that stuff, but I do think we learned arguably more from these free text responses in the patient's own words than we did for any of the stats we were able to do. And I have peppered the rest of this talk with some representative quotes in the various domains. So these are a couple patients who responded to Kelsey's question regarding bowel function. One patient who had been cured of their anal cancer said, "Sometimes I wish I had a colostomy. The bowel incontinence and passing gas with no warning bothers me the most." Another patient said, "I didn't realize how life would revolve around my bowel movements. I've got to schedule all activity as to when I feel safe to leave my home or be away from a bathroom." So Brian led this analysis for this part of the project, looking at the LARS scores and the FIQOL scores for the anal cancer cohort. And this was interesting at the time because the LARS score, it's low anterior resection score. It was really developed and validated for folks who had a low anterior resection and didn't have a rectum anymore. But what we found is patients treated with definitive pelvic chemoradiation had a lot of these same symptoms as folks who had a TME surgery. You can't compare across the cohorts, but the numbers were actually very similar, and people were having a lot of the same issues after having definitive chemoradiation. The FIQOL scores, again, were very similar. So, the question is, it's nice to know this, it's good to have it for future patient education, but it should also trigger in our minds, can we move the needle on this? Is there anything that we can do better to improve things for future patients? So Lauren Andring, who graduated a couple of years ago, and Jordan McDonald, who's a current resident at MD Anderson, got a little seed grant to put together a project, a small interventional study looking at using pelvic floor physical therapy as prehab during and immediately after pelvic radiation for anal cancer. I don't know if you guys have the same practice, but in my practice, folks are having incontinence issues or maybe LARS type symptoms. After all the mucositis heals, 9-ish months after treatment, I'll often send folks to pelvic floor PT because the strengthening and the work they can do can often help to improve continence if you can strengthen the pelvic floor muscles. So Lauren had this great idea. What if we did this proactively? What if we helped to optimize pelvic floor health and function at the beginning, give people the tools to work on this at home from the beginning? Can this help mitigate some of the fecal incontinence issues or LARS type symptoms in the survivorship period? So the study is still ongoing. I think we're trying to enroll maybe 1 or 2 patients to get to that final accrual number. But the feedback I'm getting from my patients who have been participating in this is hugely positive. I found that a lot of patients know nothing about their pelvic floors. They don't really recognize how to work these muscles and to isolate them. So having the patient education from our pelvic floor physical therapy colleagues and having something to do proactively that gives them agency as the patient through all of this, the feedback has been really good. So hopefully we see some good results in the scores as well. Okay, here is a patient survey comment that pertains to urinary function. One patient told us, "I have to frequently urinate. I consistently drink water throughout the day, and it gets very annoying as most days I will urinate about 3 times per hour." Brian analyzed our ICIQ results for both men and women. And interestingly, although we had a couple patients who reported this being a big problem of theirs in survivorship, on the average, scores did not seem to be much worse in the population of patients treated for anal cancer compared to age-matched controls. So a lot of the urinary problems people are having post-treatment may be confounded with some normal age-related changes or changes we can see having children. So, obviously trying to be proactive and do what we can in an evidence-based way to reduce the risk of some patients getting urinary dysfunction. Brian did a dosimetric analysis looking at the patients that did have worse urinary function scores, looking at bladder volume, and did seem to find a correlation with the V40. And this is in line with what we see in the rectal cancer literature as well. So we have kind of emphasized this as one of our planning goals when possible without impacting tumor coverage. Okay, pivoting again to sexual health and wellness. This patient told us intercourse was agony and never really improved at all. I started to get anticipatory fear about future pain. My husband and I separated approximately 4 years after her anal cancer treatment. So this is a sensitive topic. It's something that a lot of our patients don't necessarily feel comfortable bringing up. And in talking to my colleagues and being honest about my own experience early in practice, it's hard for us to bring up too. But it's an important one. Because when we did ask patients who were treated for anal cancer how their sex life was going, we found that over 80% of women treated for anal cancer had clinically significant sexual dysfunction as measured by the FSFI. So more often than not, our treatments are having an adverse impact on the sexual health and wellness of our patients with vaginas. We also found that you can't necessarily assume for whom sex life is an important part of their overall quality of life. We were talking about this with the residents. My patient population skews older, about 80% women. Most of my patients are in their 60s. So that means the majority of them were maybe their mid to late 60s when they were filling out these surveys. Over half of them were still sexually active and reported that as an important part of their relationship and their general quality of life. So we can't make the assumptions who is or is not having sex and who is or is not, who does or does not consider that to be an important priority in their overall quality of life. So what can we do about this? We have looked at some dosimetric correlates for worse female sexual function scores. What we have seen in our dosimetric analyses is, and this kind of makes sense looking at the geometry, we can't necessarily spare dose to the posterior wall of the vagina. That sits right up against the anal canal, right? But we can spare the anterior wall. We utilize a vaginal dilator daily during treatment for patients with anal cancer and low rectal cancers. And we found that with physical displacement and being able to spare at least 50% below 35 gray, 50 or 60% below 35 gray, at least in our retrospective data analyses, it seems to improve overall FSFI scores and particularly the question items related to dyspareunia or pain at the initiation of vaginal intercourse. So we have kind of operationalized this, and this is now what we're using as our standard of care for patients with vaginas. But this, maybe is not such a hot take. If you ask female patients what is the most important part of their anatomy for sexual satisfaction and maybe sexual wellness, it's not necessarily the vagina. And this is an up-and-coming topic of research and inquiry. My colleague Deb Marshall at Mount Sinai is doing some great work in delineating the female erectile tissues in the vulvoclitoris and other substructures that none of us really know how to contour well. Won't make the joke about not knowing how to find it. That's a low-lying joke. It's okay to laugh. It's okay. But her group is doing some great work in creating atlases so that we can delineate these structures, so we can measure dose to these structures, and we can see if female sexual satisfaction scores are related to the dose that's kind of maybe unknowingly being delivered to these female erectile tissues. So she's got an ongoing STAR consortium. Anderson is a part of that. We're enrolling patients on the STAR study. What else can we do? So we've started to get a lot more proactive in our clinics, our follow-up and our survivorship clinics, just about talking about general vaginal health and sexual wellness. There's a lot of data that vaginal estrogen is safe for basically everybody, and it can be very helpful in maintaining the health of the vaginal wall, improving the natural moisture, and reducing some of that dyspareunia. We talked about pelvic floor physical therapy already, and then there are other assisted sexual devices that can help patients to maintain their sexual health and wellness with their partner while minimizing the pain and discomfort and the psychological and relationship issues that can come with anticipatory pain, like the patient in the representative quote that I shared with you. We have a cool ongoing study right now. It was started, Lauren Andren got the grant, but then graduated and passed the project to Rahema Thomas, who's finishing it up this year. We have started this at-home sexual rehab program, kind of piggybacking on what we know in the GU space. So when we talk to men who are treated for prostate cancer, we don't have a problem asking them about their erections, right? And there's lots of medication that can help with erections. There are vacuum pumps that can help promote blood flow to the male erectile tissues. And a lot of those principles can translate. So there is a device, a clitoral vacuum device, that can be incorporated into and we're studying this in an at-home sexual rehab program with the idea that it promotes blood flow to the female erectile tissues, which naturally improves vaginal lubrication and can make orgasm easier and help with female sexual satisfaction. So Lawrence Grant bought a bunch of these devices. We've put together kind of an at-home program to utilize this device 3 times a week, in addition to using vaginal dilators post-treatment, which we do as a matter of routine. And then we've got PROs before and after to assess and hopefully see a positive impact here. So they're about halfway through the study. And again, the interim feedback has been good from patients. So it's nice to have something proactive to do to help with this issue that can be very significant for a lot of our patients. Okay, not to leave out the guys. This is a quote that pertains to male sexual health and wellness after treatment. This patient said, "Meds helped the erectile dysfunction, but I wasn't prepared for how much orgasms would change. It's so much harder for me to get there, and maybe that's partially because it hurts now when I ejaculate." And so, analyzing the IIEF-5 scores that we collected in both the anal cancer and the rectal cancer cohorts, the median IIEF score was 16, and a little over half of the patients in our cohort had moderate to severe erectile dysfunction 2 years or more after treatment. Enoch Chang, who's going to be my partner in GI RADONC next year, kind of looked at these potential predictors for male sexual dysfunction, didn't really find anything significant other than age, which would be expected. And this is maybe because of the similar target volume that we're using for a lot of these folks. We do have a well-paved or a better paved road to follow in terms of male sexual health and wellness because of all the great work done by my colleagues who treat patients with prostate cancer. We know if we want to optimize penile function, we can focus on risk reduction. It's kind of up for debate how much pelvic radiation in this day and age can impact testosterone levels, but assessing those can be helpful. We've got a whole drugstore full of PDE5 inhibitors, which can be helpful post-treatment. And then again, I have found pelvic floor PT to be helpful for my patients who are suffering with retrograde ejaculation and the pain and distress that can come from that. Here's another quote from a patient related to male sexual function. He said, "I'm a gay man and I like to be on the receiving end of sexual penetration. There was no information given to me on when or if I could ever do this again after radiation treatment." And I will admit, when I was reading these patient comments, this one really struck me and uncovered a major gap in my own patient education, my own spiel, my own conversation that I was having with patients. And I was kind of embarrassed to recognize that kind of heteronormative bias in my own patient counseling. So I was very grateful for this patient for their honesty, and it kind of triggered a whole side project to learn and better understand the unique sexual toxicities that can impact our sexual and gender minority patient populations. We have some data here in the prostate cancer space, and I think there's a little bit of don't ask, don't tell in medicine. A lot of us, we treat the patient in front of us. We try to treat them no matter, we try to treat them the same no matter what. And that can be a noble goal, but it can also be to the detriment of really knowing what is important and what is the priority of our patients so that we can tailor our care and our patient education appropriately. We know that the studies that have been published on male sexual function primarily focus on erections and the male being the penetrative partner in sex, and that is not always the priority of some of our patients in the SGM population. So I had an amazing summer student last year, Beck Gold, who did this cool project where he did a survey and qualitative interview study for men who have sex with men who were treated for anal cancer. And the study was twofold. He gave each patient kind of a comprehensive sexual health and sexual toxicity PRO written survey But then he also did like 45 to 60-minute interviews with these patients, asking them what they thought about the instruments. Were these questions and answer choices appropriate? Were there any perceived bias or things that we can improve? And then also exploring some domains of, what did your doctor talk to you about? Did they bring this up? Is this something you had to bring up? What do you wish your doctor had told you about? So the major insights from this survey, I feel like I could talk about this for an hour, but I'll give you the highlights. Rates of sexual dysfunction as measured by these existing questionnaires were high, as expected, not significantly different than the non-men who have sex with men population. And the general feedback about the questionnaires themselves was that there was maybe an overemphasis on erections and climax, which may not be the sexual health and wellness priority of all men. Most survivors reported not having conversations with their doctors, and patients really did want us to bring it up. They didn't want to have to bring it up in the clinic room. They wanted their clinic team, their physician, to be the one to initiate that conversation. Interestingly to me, there was disagreement among the patient participants on when information about sexual health and wellness would be the most helpful. I guess my own bias is that I want my patients to have all the information up front at the beginning. They can make informed decisions. But a lot of our patients told us they were too overwhelmed at the beginning to process any of that. And they would have appreciated the conversation maybe 3 to 6 months afterwards, which is interesting. Okay, getting towards the end here, here's the last patient quote I will share with you. I've had awful issues with sleeping due to being terrified my illness will come back and nightmares of the whole radiation and chemo experience. And I think this is something we've probably all seen, this anxiety, this almost PTSD-like symptom complex that our patients experience after emerging from what can be a very difficult, both physical and emotionally difficult treatment. When Kelsey analyzed the FACT-G7 scores, we found that even after patients had gotten to cure, they were on the other side of cancer, they were still having some lingering issues about energy, pain, difficulty with sleep, difficulty enjoying life, and being content with the quality of life. And patients reported that these things tended to be cyclical, with this anxiety creeping in maybe as their follow-up scan or their follow-up visit was getting closer. So, I find this information helpful to counsel my patients and to normalize that. I bring it up at the last OTV, hey, our next scans are in 3 months. The week or two before may be tough. If you are having a hard time, if you want to talk to somebody, if you don't have somebody to talk about at home or in your inner circle, reach out. And I think a lot of cancer centers are recognizing that patients with cancer need certain and specialized support, and the field of oncopsychiatry, I think, is growing both at my institution and at lots of places across the country. When Kelsey analyzed kind of the broader survey and tried to look at what symptom domains correlated most with overall quality of life, unsurprisingly, bowel function was the strongest predictor. And that makes sense. If you're pooping your pants with no warning several times a week, that's going to maybe overshadow issues with sexual function or maybe some hip stiffness or whatever. So what that tells us is if we're trying to focus our attention, focus our resources on moving the needle the most or maybe the fastest for patients in survivorship, targeting bowel functional outcomes may be the lowest hanging fruit and the best way to go. So, with our ongoing work, we have taken what we've learned about this kind of retrospective snapshot in time survey that we did with the, couple hundred patients treated for anal cancer and rectal cancer, and we have recognized that, these snapshot in time surveys have a lot of risk for bias, for flaws, right? In all of the data that I showed you so far, I did not have baseline PROs. So it's impossible for me to sit here and tell you that the LARS score was terrible because of chemo and radiation. People may have had pre-existing issues that they came with. Aging certainly plays a role in a lot of these functional domains. So the data I showed you, while they were very educational for me and my team, and I think raised additional questions and things that merit further study, they can't really tell us anything definitively. So what this retrospective work prompted was an effort by my department to be more intentional about collecting these PROs in a proactive and a systematic way. So we started this in 2022, 2023, kind of as a pilot program. We started just with patients being treated for anal cancer, enrolling everybody in a prospective study, getting this battery of PROs at diagnosis and then at standardized endpoints throughout and after treatment. And we learned a lot from this pilot study. We used REDCap to collect the survey, to administer and collect the surveys. REDCap is great, but it is separate from our medical record, so someone had to manage that database. We also learned, and maybe this was my naiveness, you guys know what I mean, that if I sent my patients a survey, they'd be like, yes, doctor, I'm so excited to fill this out for you. I'm gonna fill it out right away. But we knew survey fatigue is a huge thing. Our institutions are sending press ganies. People have a lot of demands on their time. And we found if we just sent out these surveys as an auto-send at the predefined survey intervals, the response rate was probably only like 20%. So it really took somebody being dedicated to this project, calling to follow up, meeting patients at the follow-up visit, handing them an iPad. It really takes intentionality to collect a good, comprehensive, and robust set of patient-reported outcomes. And so we've taken what we've learned so far with this little pilot, and our institution now has the ability to integrate some of these PROs into Epic so they can be administered through we use Epic as the medical record, so we can collect these and allow them to be visualized by all providers in a patient's team to use them clinically, and then maybe down the road also make them available for study or for research inquiry down the road. So we're in the process of that now, going through the many, many layers of bureaucracy to get our PROs integrated into our medical record. Another cool side project that I wanted to highlight, Kelsey did this before she graduated. She really wanted to, she was, as I was too, very grateful that our patients took the time, the ones that did fill out our surveys, to let us have it, so to speak, and give us the real truth that we needed to hear. So she was trying to think of a way to give back, and patients often said the same thing when they were filling out their surveys. I was happy to do this because I want to improve things for patients that come after me. I want people not to have to struggle with the same things or have to learn things the hard way like I did. So Kelsey led this effort to revamp our patient education curriculum, take what we learned from the feedback and the scores from our patients, and distill it and integrate it into this little 5-module anal cancer specific patient education curriculum. And she had this great idea to contact patients before their first consult with any oncologist at our institution and give them this information. And so they would watch the videos about 48 hours before their consult visit. She had a pre-test and a post-test to assess, how well the videos communicated content. But then she also looked at patient distress scores at the time of the consult visit. Because the hypothesis was knowledge is power. And if we can get patients vetted, high-level information before we see them in clinic, hopefully that brings the temperature down a little bit in the room, and honestly maybe frees up a little bit more of our time to talk about more of the patient-specific stuff and focus on building the relationship rather than just explaining to the patient, no, you won't glow in the dark, no, you won't be radioactive, kind of this base knowledge building stuff that we have to do as part of our consults. And unsurprisingly, her videos were very good. They were good at communicating content. People didn't know very much about anal cancer before they watched them. They knew a lot about anal cancer after they watched them. Patients were also very happy with the experience of getting the information this way. The vast majority of folks found them helpful and would recommend them to other patients. I will highlight the exception to these 93 and 97%. is that a couple patients were thoroughly freaked out by hearing all of this information without the benefit of having a doctor there in the room to kind of give context. So it goes to, there's never going to be a one size fits all, and that is the, I guess, potential downside to this bias that more knowledge is always better. So in terms of the patient distress scores, her hypothesis did kind of bear out. This is not a perfect comparison because this wasn't a planned randomization or anything, but she compared the folks who enrolled on her little pilot of watching the videos to those who did not enroll on the pilot for whatever reason. We couldn't get in touch with them, we couldn't consent them, whatever. And in comparing the distress scores of folks who participated in the pilot versus those that didn't, folks who watched the videos on average did have lower distress scores reported in the clinic visit itself. So while it freaked a couple people out, on the whole, it did seem to be very helpful. And I'll speak from the physician side, it did make my visits a lot more streamlined. I was able to kind of jump in, get to know the patient, talk about the nitty-gritty, and make good use of the increasingly limited face-to-face time we have with our patients these days. So, opportunities to utilize PROs in addition to kind of the work that I've described already. This is a great study. It's quite old at this point, but Ethan Bosch did this pilot many years ago where they gave patients PROs to fill out during chemo treatment. This was a study of patients with metastatic cancer receiving chemotherapy, and the system allowed them to fill out PROs, and they went into this computer system, and it flagged the clinical team if their PROs were above kind of a certain threshold. And in this study, I think they had a team of oncology expert nurses who would get the flag. They would see the scores took a jump or increased over the threshold. They would reach out to the patients and see if they needed to adjust something or intervene. And they found that not only did this keep people out of the emergency room, reduce treatment breaks for chemotherapy, but there was also an observed survival benefit in the patients that had the use of PROs and real-time evaluation of those PROs by the clinical team as part of their routine care. So this is something I'm really hoping we can integrate into our clinics as we get the PROs into Epic, where we can see them, where they can be sent as a flagged result, similar to a CBC or a chem panel. This is also kind of my pie in the sky dream. I'm waiting for a resident to come to MD Anderson who's like good at app development and all that tech stuff, because what I would love, in addition to the clinical team getting the flag, if the PROs are above or below some kind of threshold value, is I would love to give that information and that feedback back to the patients. I don't know if you guys have ever filled out a survey, like SurveyMonkey will give you a survey, and then you'll see like what your answers were compared to how everybody else responded. What if we could do that for patients and the PRO scores of people with their cancer, with their treatment at the same time point where they are? I think it could give context and maybe reassurance in some ways to patients that, yeah, I feel like crap, but I'm supposed to feel like crap. This is the 5th week of pelvic chemoradiation. Everybody else feels that way as well. But also, it could maybe flag folks who are scoring, again, above or below what we would expect for a patient with their cancer at that point in treatment. And in addition to flagging the clinic team, flag the patient themselves. Hey, call your doctor. This is not what we would expect for week 1. You should reach out, schedule another appointment. So if any of you smart residents know how to make apps and do this kind of stuff, hit me up. Additionally, I think in general, I would love to see a little bit more intentional, organized support of our patients as they navigate their survivorship journey. I think we are very good at diagnosing patients, at staging them, at treating them, at managing the toxicities we cause during treatment. And then, for a long time, our oncology community is kind of like, you're welcome, your cancer's gone, see ya. And patients are left to navigate this part of their journey largely on their own or looking for online support groups or other kind of peer-led resources. So again, this is my pie in the sky perfect world dream. I would love to see more dedicated survivorship clinics maybe clustered around disease sites. Again, I treat a lot of disease in the pelvis. So I would love to have like a pelvic cancer survivorship clinic that pooled all of these experts, co-located them for patients to access should issues arise during their survivorship care. Oftentimes, we'll need to pull in colorectal surgery. We talked about oncopsychiatry, sexual medicine. We always need more pelvic floor physical therapists. I feel like their wait time is always longer than we'd like it to be. And the rest of these experts seen here. Right now, survivorship care, even at big cancer centers, big institutions, is often kind of piecemeal. And often the oncologists, the radiation oncologists and other oncologists take a little bit of a back seat once patients pass 2 years NED or 4 years NED or whatever the definition of cured is. So anybody who's interested in hospital administration or cancer center leadership or has some pull would love to see this in the future for our patients. So now kind of getting to the end, I wanted to highlight why this is so important to me personally and why I think we should all care and dedicate a lot of intentionality and interest to life after cancer. A lot of people do get there ever after. They get through their cancer treatment, they get that, magical designation of no evidence of disease and then cure, and they get to live the rest of their life after their cancer is done. And so focusing as much attention and intentionality on survivorship issues, I think we owe it to our patients. So this is probably my crowning moment, my best moment in my whole career. This is a patient I treated for anal cancer. She had just started, she was in her 60s and had just met, and was single and had met this guy, had just started dating. She got cancer, came to Houston for treatment. The guy came with her. It was a very sweet guy. And so he went through her cancer journey with her, and I got to know them both very well during treatment. About 2 years after her cancer treatment, she was NED, he proposed to her, and they were planning a wedding. They were in their late 60s at the time. Neither of her parents were living. So myself and her medical oncologist got to walk her down the aisle for her wedding. And, I'm not going to cry, but this is why we do what we do, to build the relationships with our patients, to focus on their happily ever after, to their life after cancer. So shameless plug for more survivorship research and late toxicity and functional outcomes work. So thank you guys again for the invitation, for your kind attention today. I want to shout out the amazing group of residents and medical students who've been kind enough to work with me on this stuff over the years, and honestly, to have a lot of these great ideas that stemmed the projects that I showed you today. Too many to name, but you can see their beautiful faces in these photos. We call it the Holliday Non-Lab. That's what we do. I also want to give a shout out to my patients who did generously give their time to fill out our surveys, to engage us in this conversation, and going back to 2020, to the patients and caregivers and advocates whose brutal honesty shine the light on how far we still have to go. So, thank you.
Thank you, Dr. Holliday, for a wonderful presentation. Before we take any questions, I just want to give a shout out to next week. We hope you'll join us for our next Grand Rounds lecture on January 21st, featuring Dr. Rami Sedum, University of Pennsylvania Perelman School of Medicine. For details on upcoming lectures, please visit the Winship Cancer Institute of Emory University's website and check the Winship calendar. Any questions from the group?
I'm Hanya Halak, Director of Medical Physics here in Radiation Oncology. That was an amazing talk. I have a follow-up about the videos that you showed patients. There are initiatives across the country to do medical physics consults with patients where they do meet with them maybe at the beginning, midway, and at the end. It's been shown to kind of allay anxiety, and all these technical questions that you mentioned, are answered by the physicist. Have you thought about that initiative in adding to the videos?
Yeah, I think it's a great thought. I'm aware of the ongoing stuff. I've been speaking with our physics colleagues at Anderson, and there is definitely interest. I don't know about you guys, our medical physicists are pulled in so many directions that protecting the time for them to be in clinic and be patient-facing is sometimes a logistical challenge. But I think a nice maybe supplement to some in-person interactions would be to have a little bit more physics collaboration in the pre-consult curriculum. We're currently working on the beta version. The initial version of these videos were very crunchy. It was like a PowerPoint with a little talking head. So we're working on making them nicer and prettier. That would be a great improvement for the beta version. Thank you.
Thank you for the wonderful lecture. Just as a corollary to, for us, we often refer patients to physical therapy for lymphedema prevention and things like that afterwards. Have you guys changed systematically how you refer patients after chemoradiation for GI cancers? And how do you think about how much the radiation oncologist should provide versus how much support services should provide in kind of managing some of this?
That's a great question, and why I think like a co-located, like just like we approach cancer in a multidisciplinary way, like approaching survivorship and toxicity management, I think is also done with a concerted multi-D team. To answer the first part of the question about pelvic floor PT referrals, we're waiting for the results of the pilot because we need more staffing. The problem with pelvic floor, I would love to send every single one of my patients to pelvic floor PT from diagnosis, because I think we can all optimize our pelvic floor health, and then some proactive exercises I think are going to end up being super helpful. But we don't have, even at Anderson, we don't have the resources to do that because our GU patients use that, right? Like my GYN patients, my patients are not the only, like I could probably employ 2 full-time pelvic floor PTs with my own patients. So we're hoping we can staff up our department in the future. There also is actually a pelvic health clinic that is in the planning stages at Anderson, which will have a bigger pelvic floor PT presence. So I think it's coming. And what I would love to do versus what is possible with the resources that we have are not quite matched at this moment. And then, to answer the question about who should do what, and I think the ball's in our court, especially with anal cancer and radiation. It's easy because we are the direct causers, right? I'd love to blame my surgeons and my medical oncologists for stuff when I can, but we have to take the ownership for that, right? So, I think we're the quarterbacks first and foremost, and when we have good multidisciplinary colleagues to help support with more expert level stuff, then obviously we make those referrals. But the conversation needs to start with us, I think.
Thank you again, and I'll check to see if there's any online. I'm not sure, but yes, let's see if there's any. Sorry. Okay.
There's a lot of CME.
Yes.
Good.
Don't forget to get your CME. Thank you, and we'll see everyone next week.